Welcome to the Antihypertensive Medication Overview module. The following module will provide you with a brief overview of antihypertensive pharmacotherapy as well as appropriate indications based on specific patient populations and adverse drug effects of the medications. Thank you for taking the time to complete this module. We hope it will be a good refresher on the treatment of hypertension. This module will include the following objectives. Recognize the importance of antihypertensive medications in patients with high blood pressure. Explain how to treat patients with hypertension. List the classes used to treat hypertension and how these medications work to lower blood pressure. Identify appropriate medications used for specific patient populations and indications. Describe the side effects associated with each class of medication. Suggest ways to intervene with a patient experiencing side effects with their antihypertensive medication. It is extremely important for patients with hypertension to meet treatment goals. Most patients will require medications along with lifestyle modifications. Many antihypertensive medications have not only been shown to lower blood pressure, but to also decrease other cardiovascular events such as heart attack and stroke, which leads to decreased morbidity and mortality. This slide is an algorithm for the treatment of hypertension. Specific drug classes are indicated for hypertension alone versus hypertension with compelling indications. For stage 2 hypertension, it is recommended to initiate combination therapy, whereas in stage 1, you may initiate monotherapy. For patients with compelling indications, studies have shown that certain classes of antihypertensive medications have a greater benefit over other classes. In the next few slides, we will discuss the recommended drug classes for each compelling indication. In patients with heart failure, ACE inhibitors are indicated as first-line treatment. They have been shown to have a better effect than ARBs, but ARBs may be used if there is a contraindication to ACE inhibitors. Beta blockers are also indicated for all stages of heart failure. The beta blockers of choice in heart failure are metoprolol succinate, known as Toprol XL, carvedilol, and the less commonly used bisoprolol. Diuretics should be used for symptom relief of fluid overload. Loop diuretics are more effective in reducing fluid volume than thiazides in heart failure. Aldosterone antagonists such as spironolactone or eplerenone should be considered in patients with stage 2 to 4 heart failure. Do not initiate these medications if the serum creatinine is greater than 2 or potassium levels are greater than 5 because of the risk of hyperkalemia. Patients that have had an MI or heart attack usually require a combination drug regimen. ACE inhibitors, ARBs, and beta blockers have been shown to reduce morbidity and mortality in patients that have had a heart attack. Aldosterone antagonists, specifically eplerenone, should be initiated in patients within 3 to 14 days of a heart attack. It has been shown that patients with a high risk of coronary heart disease will benefit from thiazides, ACE inhibitors, beta blockers, or calcium channel blockers. All of these drug classes have evidence for the prevention of cardiovascular complications of hypertension. The choice of agents will depend on patient-specific factors such as contraindications, adverse effects, and cost. Patients with diabetes usually require a combination of 2 or more drugs to achieve a blood pressure goal of less than 140/80. All patients with diabetes should be treated with an ACE inhibitor or ARB unless contraindicated. These drugs have a benefit of slowing the progression of nephropathy and reducing albuminuria. Thiazide diuretics are recommended as the first add-on agent. Beta blockers and calcium channel blockers are also beneficial in reducing cardiovascular events in patient diabetes. Patients with chronic kidney disease usually require a combination of 2 or more drugs to achieve a blood pressure goal of less than 130/80. ACE inhibitors and ARBs have shown a favorable effect on the progression of renal disease and should be used in chronic kidney disease patients with stable renal function unless a contraindication exists. You may see a limited rise in serum creatinine as much as 35% in any patient started on an ACE inhibitor, which is acceptable. However, you should avoid these drugs if acute kidney injury is present or the serum creatinine becomes unstable. In the treatment of recurrent stroke prevention, TIA and ischemic stroke rates have been lowered by the combination of an ACE inhibitor and a thiazide diuretic. The remainder of this module will cover each antihypertensive drug class. We will discuss the mechanism of action, contraindications, and side effects of each class individually.
Diuretics decrease extracellular fluid volume through diuresis, which decreases cardiac output and in turn decreases blood pressure. Thiazide diuretics such as HCTZ are considered first-line treatment as monotherapy or combination therapy for hypertension. Loop diuretics such as furosemide or bumetanide are more effective in patients who are fluid overloaded. Potassium-sparing diuretics are useful when used in combination with other diuretics that cause decreased potassium levels. They are normally not used alone. Diuretics have a number of adverse drug effects that need to be monitored. Thiazide diuretics are not as effective in patients with creatinine clearance less than 30 milliliters per minute. Diuretics can also cause electrolyte disturbances, such as decreased potassium and sodium. It is important to monitor these electrolyte levels and discontinue the diuretic if the levels get out of range, or initiate a supplement to help balance the electrolytes. Thiazide diuretics should be used with caution in patients with gout. They can increase uric acid levels, which worsens gout. Renal dysfunction can also occur, so it is very important to monitor BUN and serum creatinine while on diuretic therapy. Glucose disorders such as hyperglycemia or glucose intolerance may occur with thiazide diuretics, so monitor signs and symptoms of these disorders as well. It might not be necessary to avoid thiazide diuretics in patients with diabetes, but the benefits need to outweigh the risks. Some common side effects of diuretics include excessive urination and muscle cramps or weakness. Remind your patient to take their medication in the morning to avoid nocturnal diuresis. If the patient reports muscle cramps or weakness, please refer them to their primary care provider to get their potassium levels checked and consider adding on a potassium-sparing diuretic or initiating a potassium supplement. ACE inhibitors cause arterial and venous vascular dilation by inhibiting an enzyme responsible for the conversion of angiotensin I to angiotensin II, which is a potent vasoconstrictor. This results in decreased blood pressure. There are several instances where ACE inhibitors should be used with caution. Pregnancy is an instance when ACE inhibitors are absolutely contraindicated due to their effects on the renin-angiotensin-aldosterone system. A common side effect of ACE inhibitors is a dry, hacking cough. If this occurs and is intolerable to the patient, you can contact the primary care provider about switching to an ARB. A serious adverse drug effect of ACE inhibitors is angioedema, which presents as swelling around the lips and face. If this occurs, you should discontinue the ACE inhibitor immediately and change to another antihypertensive medication, not including an ARB. Acute renal failure can also occur while taking an ACE inhibitor. Modest elevations of serum creatinine of less than 35% for a baseline serum creatinine of less than 3 or an absolute increase of less than 1 do not require a change in medication. You should monitor BUN and serum creatinine and discontinue the medication if these levels continue to rise. ACE inhibitors can also cause increased potassium levels, so it is important to monitor potassium levels when initiating these medications. ARBs have the same mechanism of action as ACE inhibitors. They cause arterial and venous vascular dilation by inhibiting an enzyme responsible for the conversion of angiotensin I to angiotensin II, which is a potent vasoconstrictor. This results in decreased blood pressure. ARBs have the same adverse drug effects of ACE inhibitors, with the exception of the cough that is only associated with ACE inhibitors. ARBs are absolutely contraindicated in pregnancy. If angioedema occurs, you should switch to a completely new class of antihypertensive medications, and you should use ARBs with caution in patients with unstable kidney function and high potassium levels. Beta blockers inhibit beta adrenergic receptors, which cause a slowed heart rate and reduced cardiac output. They also decrease renin release, which causes vasodilation and therefore reduces blood pressure. There are several instances where beta blockers should be used with caution. Since they cause a slowed heart rate, you should not use them in patients with a heart rate of less than 60 beats per minute. You should monitor the patient's pulse rate if you suspect a low heart rate and change to another medication if necessary. In patients with asthma or COPD, you should be sure to use a cardioselective beta blocker, such as atenolol, bisoprolol, or metoprolol, to avoid respiratory distress. In patients with severely uncontrolled asthma or COPD, you may need to discontinue the beta blocker and choose a better option. Beta blockers can mask the signs of hypoglycemia, so it is very important for diabetic patients taking beta blockers to monitor their blood glucose levels regularly and consider alternative medications if they are frequently having low blood sugar. Many patients may still experience sweating as a symptom of hypoglycemia while on a beta blocker. This class of medications is more likely to cause rebound hypertension stopped abruptly, so please counsel your patients on the importance of adherence. Some side effects of beta blockers include fatigue and depression. In many instances, these effects will subside 3 to 4 weeks after starting therapy. If these effects continue after 3 to 4 weeks or are intolerable to the patient, it may be necessary to contact their primary care provider to switch medications. Sexual dysfunction is another side effect that usually won't subside if it occurs, but it is reversible upon discontinuation of the beta blocker. Calcium channel blockers inhibit the entry of calcium into cardiac and smooth muscle cells. This results in smooth muscle relaxation and dilation, which leads to increased myocardial oxygen delivery and decreased blood pressure. There are two classes of calcium channel blockers, non-dihydropyridines and dihydropyridines. The non-dihydropyridines are verapamil and diltiazem, and they cause side effects such as bradycardia and worsening heart failure because they decrease heart rate and force of contraction. You should monitor the heart rate with these medications, especially if used in combination with a beta blocker, and if these side effects occur, you should contact the primary care provider about switching to another medication. Dihydropyridines such as amlodipine, nifedipine, and nicardipine can cause lower extremity edema because they cause peripheral vasodilation. Therefore, these drugs should be used in caution in patients with angina or a previous MI or patients with lower extremity edema. You should counsel your patient to watch out for ankle swelling when taking these medications. Some side effects of non-dihydropyridine calcium channel blockers include GI complications such as constipation and GERD. Some side effects of dihydropyridine calcium channel blockers include flushing and headache. Counsel your patient to contact you or their primary care provider if these side effects occur and are intolerable so you can switch to another medication.
Another class of antihypertensive medications is alpha agonists. These medications stimulate central alpha-2 receptors in the brain, inhibiting the release of norepinephrine and causing decreased sympathetic outflow. This results in decreased heart rate and vascular resistance, which leads to decreased blood pressure. Clonidine is an add-on medication for treatment-resistant hypertension. Side effects of this medication include drowsiness, headache, hypotension, bradycardia, and rebound hypertension. So it is important to counsel your patient on the importance of medication adherence. Methyl-dopa is the drug of choice for hypertension during pregnancy. This is an important point to remember. Side effects of this drug include drowsiness, hypotension, and autoimmune reactions. Another class of antihypertensive medications is the aldosterone antagonist, which includes spironolactone and eplerenone. A common side effect of these medications is increased potassium levels, so it is important to monitor labs. Also, spironolactone may cause gynecomastia, but eplerenone is more selective, so it does not cause this side effect. If your patient develops this side effect on spironolactone, you may switch to eplerenone. Thank you for completing this module. We hope it provided valuable information that will be beneficial when treating your patients with hypertension. Please proceed to the next required module, medication adherence.